Welcome to the Minnesota Senate. We're in room 1100. It's Friday, May 10th. It's our Human Services Conference Committee, and I want to thank those that follow the Senate tradition of wearing a tie. Oh, wait, I'm sorry, Senator Abler.
Mr. Chair.
Yeah, it was Senator Abler.
Isn't there a winter and a summer dress code? Have you been outdoors?
No, sir, I have not.
These people all deserve whatever they have in the bill just for being inside now.
All right.
So this is my way to encourage them. Thank you, Mr. Chair.
Thank you. So you hold Mr. Herring gets off on that one, so we're good. You just saved him. So with that, we have a pretty full plate. We're going to go through, of course, we're called to order, but then we're going to look at the Senate File 5335. We're going to have Kyle Raymond and Doug Berg run us through side-by-sides. And then also Leah Monahan and Danielle Pinelli then will go on the, the summary side of it. And then we have testifiers, members that, there's 10 people that have signed up to kind of talk. We've kind of limited that to 2 minutes each. But want to be able to have members to be able to have the conversation like we did in our policy committee and really have a robust conversation on that. So with that, I want to go around and we'll start with Representative Neuer, if you want to represent who you are, and welcome to the Senate.
Thank you, Mr. Chair. I look forward to a robust discussion on this conference bill. And Mahmoud Noor, I'm the Chair for Human Services in the House, and maybe we can go around for introduction, Mr. Chair.
Sounds good.
I am State Representative Kristen Bonner of Maple Grove, a Vice Chair for the Human Services Committee.
Senator Abler?
Hi, Jim. Used to be from the House.
Used to be, I know, because you're not wearing a tie. And Senator Omar Fateh, do you want to introduce yourself to folks so they know who you are?
Yes, Omar Fateh, Vice Chair on the Senate side.
And he's doing the same thing Jim Abler is doing. Mary Franzen, you're on Zoom land. You want to say hi to people and introduce yourself?
Hello, members. Representative Mary Franzen here, present. Super excited to be here.
Good to have you here all the way from Wright County. So I think we'll start. Sean, if you just want to start, and then we'll just go around the room and introduce people. So thank you.
Yeah, Sean Herring, Committee Administrator for the House Human Services Finance Committee.
Danielle Pinelli from House Research.
And our House Finance guy who's wearing a tie, Mr. Berg.
Mr. Chairman, members, I'm Doug Berg. I'm the Fiscal Analyst for the House Human Services Committee.
Mr. Chair, members, I'm Kyle Raymond, Senate Fiscal Analyst to the Human Services Committee.
My name is Cassie Soar. I'm the CLA for Human Services in the Senate.
Liam Monahan, Analyst with Senate Counsel.
David Zach, CA of Human Services.
And then it looks like, and folks, it looks like Jonathan Cotter's on, he's online. He is a House Caucus researcher. We also have Joe Durheim, who's here as well. Then the Emily Spatera and Bryce Hinkst are back there. They're our Senate Caucus researchers. And then we have our pages that are here. If anybody needs to get a note to us, our pages, and I didn't write your names down because I didn't know who. It looks like CJ. And thank you. If you got that, you can get that to it. So Fardusa is here as well. Ali, where are you? There she is. So welcome to the Senate, by the way. Having that, did I miss anybody? Mr. Raymond, Mr. Berg, talk to us.
Thank you, Mr. Chair, members. Again, for the record, Kyle Raymond, Fiscal Analyst, Senate Human Services. So today, Mr. Berg and I will be walking through the Human Services Supplemental Budget Spreadsheet. And just, I'll note that we're using the spreadsheet that is in the bottom right-hand corner. The timestamp is May 8th at 10:48 a.m. So to start, I'll note that the governor's budget items are the biannual items are the biannual totals are shown, and for the House and Senate position, we have annual and biannual totals shown. The first page is largely, the first half of the first page is summary information. So starting on lines 12 through 20, this shows the all agencies total and by fund beneath the line 12 that shows the all funds total. As you can see, for the governor and the House, the full amount is general fund dollars on line 13, and then for the Senate, there is some state government special revenue fund dollars on line 14. I'll also note that on line 10, both the House position and the Senate position meet the target of $42,130,000 in the 24-25 biennium and the 26-27 target of $14,860,000. So next I'll move to lines 50 through 85. This shows the agency total broken down by fund as well. And then I'll move to line 115, and I'll just note here for the sake of time, this now includes the, from here on, includes just specific proposals that are included in each position. It's organized by agency, and we'll, for the sake of time, we'll just go over the top line totals. However, if members have any questions, we're certainly happy to go deeper into each one if questions arise. I'll also note here that if there is a $0 total, if it's a total that a proposal that includes a cost, that means it's not included in that position. In general, we'll skip over those and unless it's relevant to note otherwise. I'll also note here if a pound sign or hashtag sign is included, that means it's a budget neutral proposal that is included in that position. So now starting with the Department of Human Services, the first proposal I'll note is on line 117. This is the governor's proposal that expands access to direct care and treatment psychiatric beds. I will note here that this is not included in either the House or the Senate bill. However, an amended version is included starting on line 124. So moving to line 124, this is a proposal for priority admissions modifications. The House funds this proposal at just under $2.6 million in the first biennium and just under $9 million in the tails, whereas the Senate funds this at just under $5.7 million in the first biennium and about 10.2 in the tails. And I'll note here that each proposal, the House and the Senate proposal, include the governor's proposal on line 117, with the exception of the governor's proposal included a closure of a Carlton Cares facility, and that the costs of that closure was used to offset the cost of the proposal. So on line 124, each, the House and the Senate position includes ongoing funding for the Carlton Cares facility. So I'll move next to page 2, line 140. This is the governor's proposal related to acute care transitions for people with disabilities and complex health conditions. The House funds this proposal at $843,000 in 24-25, and then in the tails, it is funded at $4,000 ongoing. The Senate funds this proposal at $940,000 in fiscal year 24-25, and just over $6.2 million in the tails. This is roughly the governor's numbers, though slightly under. One thing I'll note about this, the Senate proposal does not include the PCA, a study to include PCA services in hospitals. However, the Senate does include on line 163, it amends an existing proposal for a similar purpose and extends the reporting date to a similar end of what is included under the acute care transitions proposal. So just wanted to note that.
And Mr. Chair, picking up on line 165 at the bottom of page 2, this is the reducing recidivism and preventing overdoses item, also called the reentry waiver, is typically how it's referred to now. The governor did have a position on this. There's been some slight changes of, you'll see that the House has $4.9 million approximately in 24-25 and $8.332 in the tails. It's essentially the same as the governor's proposal, but some of the money when the tails was moved forward. The Senate has a lesser proposal that has $636,000 in the first biennium and nothing in the tails, and that is for a specific item, which you see on the next page on line 173, which is the bridging benefits, staffing largely. Moving on to line 182 is governor's proposal for changes to the opioid allocation modifications and the council membership. That is in all both positions and the governor's. And then on line 184 is an item that was in the governor's position and in the House position, but is not in the Senate, which repeals the sunset for the fee on opioid manufacturers, and that is different between the two houses. Line 186 is the governor's item to establish a human services contingency response account. The governor put $10 million in there. The House has a net of $606,000, and the Senate does not include that position. On line 192, the House took on an amendment on the floor to add a 3% substance use disorder provider rate increase. That's funded at $894,000 in 24-25. And I will note that the nature of the amendment pays for the tails by reducing DHS administrative appropriations on line 195 and reallocating those to the rate increase. That is something that the department has strong concerns about. I'll speak for them on that. On line 197 is the governor's proposal for the sunset of the disproportionate share program. The House funds it at the governor, or takes the governor's savings of $4.1 million in 24-25 and $8.9 million in the tails.
And next, Mr. Chair, we'll go to line 202. So this is an alternative Senate position to the governor's disproportionate share sunset. So this instead would lower the rate floor for the disproportionate share program to $141 per day. So, and this results in a state savings of it's a savings of $948,000 in the 24-25 biennium and $6,179,000 in the tails. Okay.
I'll do this. On line 207 on page 4 is hashtags for an item that's in all positions, which is the Direct Care and Treatment Separation Authority. Then, in addition, in the House, if you go to line 210, there is what's called the Direct Care and Treatment Executive Board established. That's also established in the governor's language. But the House sets up a council, an advisory council, which would exist for 2 years. And that has a one-time cost of $482,000. Moving on to line 215 is the 2023 budget bill technical cleanup. The House and Senate are identical on this. These are technical items that needed to be corrected from the 23 bill. They have a net cost of 0 in both biennia, and the House and Senate are identical on this position. Moving on to line 222, this is elimination of parental fees. This is identical in the House and Senate and has a cost of $239,000 in the 24-25 biennium and $478,000 in the tails. And on line 226 is a House-only item, which is preparation for a health-related social needs 1115 waiver. That's $709,000 one time. I'll note that this obviously does not actually start the waiver. This is the preparatory work that the department needs to do to get ready to ask for the waiver. So the legislature would need to give them the authority for that later.
So, Mr. Chair, members, moving next to line 232, this is a Senate-only proposal that would establish a temporarily available exception to the moratorium on licensing new community residential settings. So this is a budget neutral proposal. Moving next to line 234, this is also a Senate-only proposal that modifies HCBS standards for out-of-home respite services for children. So this is funded in the first biennium at $155,000, and then in the 26-27 biennium is just under $1.7 million. Moving next to line 239, so this is a Senate-only proposal that modifies the electronic visit verification system. This relates to, the modifications relate to data access for vendors. This proposal has a systems cost of $163,000 in the 24-25 biennium, and then $300,000 in the 26-27 biennium. Moving next to page 5, line 243. This is a Senate-only proposal that includes MnChoice's assessment modifications. So this includes making permanent an existing temporary exemption for certain assessments performed by contractors, and also extend some timelines for responding to requests for an assessment. So this is a budget neutral proposal in Senate only. Moving next to line 245, this is a proposal to increase the transitional support reimbursement maximum allowance to just over $4,100. Under current statute, that amount is $3,000. So this is a Senate-only proposal funded at $240,000 in the 24-25 biennium and just over $1.2 million in the 26-27 biennium. Moving next to line 249, this is a Senate-only proposal that codifies consumer-directed community supports option provisions and is budget neutral. Moving next to line 251, this is a proposal that makes a disability waiver technology provision modifications. So it would permit technology costs related to remote support to be included, but wouldn't adjust the rate encumbrance under DWRS, which is why it does have a cost, but they are systems costs only. So this is funded in the Senate position only at $786,000 in fiscal year 2025, and this one would have carry forward authority through fiscal year 2027. So moving next to line 257, this modifies a grant appropriation initially enacted last year. These are the provider capacity grants for rural and underserved communities. So this proposal would change the eligibility requirements and would specify under the appropriation made last year that $250,000 of that amount would be for a competitive grant to nonprofit organizations to conduct culturally specific outreach and education for customized living providers. Moving next to line 259, this is a Senate-only proposal that is budget neutral and modifies a definition for the long-term care workforce grants for new Americans, which was enacted last year. Moving next to line 261, this would fund a Family Residential Services Advisory Task Force. The funding is provided in the Senate position only at $653,000 in fiscal year 2025, and carry forward authority would go through fiscal year 2027. Moving next to line 267, this is a proposal to authorize assistive technology lead agency partnerships and is included in both the House and Senate positions. Moving next to line 269, this would require the Department of Human Services to draft legislation related to the CFSS worker overtime modifications, and this is funded in the Senate position only at $5,000 in fiscal year 2024.
And Mr. Chair, moving to line 273, both the House and Senate have funding for a disability services continuous improvement study. The House's funding is $614,000 one time in 24-25, and the Senate's funding is $250,000 one time in 24 and 25.
So moving next, Mr. Chair, members, to page 6, line 279. This would provide grants for home care service providers to partially offset the cost of the electronic visit verification implementation. So this is a Senate-only position that's funded at just over $1.7 million in fiscal year 2025 and is one time. Moving next to line 285, this would fund emergency relief grants for financially distressed EIDBI providers. This proposal is a Senate-only proposal that is funded one time at a cost of $648,000 in fiscal year 2025.
And Mr. Chair, on line 291, we have an item that is in both House and Senate is funding for the Own Home Services provider capacity building grants. The House has got this at a net of $1,468,000 one time in 24-25, and the Senate funds it at a net of $5,272,000 one time in 24-25. Moving on to line 297 is a bill that establishes a pediatric hospital-to-home transition pilot project. The House and Senate are identical on this item. It is at a cost of $1,324,000 one time in 24-25. Mr. Chair, on line 304, the House has a basket of changes to peer recovery the peer recovery statutes. It has a net cost of $483,000 in 24-25 and $698 ongoing. And on line 311 is a item where the House and Senate are also identical. This is funding for personal PCA services provided by parents and spouse. This bridges between the last time we did this, which ran out in, I believe, December 31st of last year, through the start of CFSS, where it is a covered service. The House and Senate are doing the same thing here. It costs $4,834,000 in 24-25 only.
Mr. Chair, members, moving to page 7, line 318, this is a Senate-only proposal that modifies small assisted living facility food code requirements and is budget neutral.
Okay. And on line 320 is a House-only provision that does two things. It establishes a housing support study to look at supportive housing rates and making it easier for homeless people to access housing as supportive housing. And it also establishes an Office of Homelessness at the Department of Human Services since after the change in in various departments. The residual department has the housing items at this point, and but does not have sort of an office to administer those anymore. This has a net cost of $854,000 in 24-25, and ongoing costs of $822,000 in the tails. On line 327 is a somewhat cryptically named House item called community-based entity grants that puts money out for, in other long-term care grants for within an existing grant program. And I will note that the Senate has a very similar item on line 399, which is possibly a little better titled as funding for linguistically and culturally specific training. But back on page 7, the House has got $2,706,000 one time for this in 24-25. Moving on to line 336 is a Hennepin County Youth Peer Recovery Project. This is a House-only item that has net cost of $500,000 in 24-25 only. On line 340, the House has an item that is a study of navigator reimbursement costs and rates and what navigators are being paid. That has a net cost of $392,000 in 24-25 only. On line 346, the House has a House-only item to study redesign of the targeted case management system. It has a cost of $380,000 in 24-25, an ongoing cost of $152,000 in the tails, and again, it's a House-only provision.
Mr. Chair, members, moving next to page 8, line 352. This is a Senate-only proposal that provides additional funding for caregiver respite care services grants. And this is funded one time in fiscal year 2025 at just over $4.3 million. Moving next to line 359, this is a Senate-only proposal that would provide funding for a property rate payment increase to 4 nursing facilities. And this is funded in fiscal year 24-25 at $288,000 and then just over $1 million ongoing. Moving next to line 363, this is Senate-only proposal that increases the property rate under the moratorium exception process for a nursing facility in Minnetonka. This is a budget-neutral proposal. Go ahead.
Okay. Line 365 is an item that is somewhat similar in both houses, but different funding levels. This relieves counties of debt that they owe on cost of care payments owed to Department of Human Services. The House exempts Beltrami County for $336,000 one time. The Senate pays for both Beltrami County and Todd County for $724,000 one time. On line 370, the House puts $7.685 million in 24-25 into the nursing home loan program that was created last year in the nursing home bill. And then there are, when you get to the language parts, I will describe there, the House language changes this into a revolving loan fund and expands the types of facilities that are eligible.
So, Mr. Chair, members, moving next to line 374, this is a Senate-only, included only in the Senate position, provides funding to establish an engagement services pilot project of $250,000 in fiscal year 2025. I will note there is a similar proposal included in one of the governor's proposals for the House. I think it's an expanded version of this, and I believe it's funded at $1 million one time. So moving next to line 378, this will provide temporary free communications for patients and clinics of certain direct care facilities. So this would cover the service costs associated with this for 2 years. This is funded in the Senate position only at $292,000 in fiscal year 2025. Moving next to line 382, this is a cancellation and carry forward for the direct care services pilot project. This was funded in the Human Services Omnibus last year, so this would give them through fiscal year 2026 to complete the activities. Moving next to line 386, this is a Senate-only proposal that provides funding for the Health Awareness Hub pilot project as well as Chapter 245D HCBS compliance supports grants. This is a Senate-only proposal and funded at just over $1 million in fiscal year 2025. Moving next to page 9, line 391. This is a Senate-only proposal that provides funding for caregiver support programs with an ALS-specific respite service. This is funded one time in fiscal year 2025 at a total of $5 million. Moving next to line 395, this is a Senate-only proposal that would provide a capital improvement accessibility payment for adults with developmental disabilities. I believe this is in Anoka County and is funded one time in fiscal year 2025 at $400,000. Moving next to line 399, and I believe this is the proposal Mr. Berg referred to earlier, a Senate-only proposal that provides funding for linguistically and culturally specific training. This is funded one time in fiscal year 2025 at $650,000.
On line 403 is an item that is identical between the House and the Senate, which is establishing a Dakota County Disability Services Workforce Shortage Pilot Project that has a cost of $1.206 million in 24-25 only. And as I say, the House and Senate are identical on that item.
Mr. Chair and members, moving to line 409, this proposal is a Senate-only proposal that provides funding for artists with disability support grant. This is funded one time at $690,000 in fiscal year 2025. Moving next to line 413, this is a Senate-only proposal that would provide funding for a grant to Accessible Space Inc. to temporarily offset ICS nursing costs, and this is funded at $250,000 in fiscal year 2025 and is one time. Moving next to line 417, this is a Senate-only proposal that would provide additional funding for self-advocacy grants.
Wow.
This is funded in fiscal year 2025 at $648,000 and is one time. Moving next to line 422, this is a Senate-only proposal that would provide a one-time rate adjustment for critical access nursing facilities. This is funded in fiscal year 2025, one time at a cost of just under $3.3 million. Now moving to page 10, line 426. This is a Senate-only proposal that would implement opioid treatment program rate methodology modifications 1 year earlier. Rather than January 1st of 2026, it would move it to January 1st of 2025. This is funded one time in fiscal year 2025 at just over $1.7 million. Moving next to line 434, this is a Senate-only proposal that would provide grants for CWA's South Asian Persons of Neurodiverse Abilities program, as well as the senior program. This is funded one time in fiscal year 2025 at $500,000. Moving next to line 438, this is a Senate-only proposal that would retroactively extend the completion date for the Centers for Independent Living HCBS Access Grant, and this is a budget-neutral proposal.
And Mr. Chair, starting on line 440 is a House-only provision that would establish a background studies contract review. The contract here with a third-party vendor is meant to determine whether the Department of Human Services could become a fingerprint vendor itself, rather than there have been some issues with the private entity that is involved now. This has a net cost of $340,000 one time in 24-25. Then on line 445, both the House and Senate are taking, it's called administrative underspending. This is a net reduction based on FTEs that were paid for in the 23 bill, but which the department has not been able to hire in the current year. And this is the portion that is attributable to Chapter 61 from last year. And as I say, they're the same on the House and the Senate, a savings of $2.438 million in 24 only.
And Mr. Chair and members, moving to line 449, this is a withdrawal management grant underspend of $500,000 in fiscal year 2024. This is identified with the department at risk of potentially canceling at that amount. So now moving to the Department of Health, moving to line 505, this is a Senate-only provision that would establish a community care hub grant. This is funded one time at $554,000 in fiscal year 2025. Moving next to line 510, this is Senate-only provision that would modify assisted living facilities, staff training, and this would be a state government special revenue fund expense of $12,000 in fiscal year 24-25, and then $48,000 ongoing. Moving to page 11, line 514, this is a Senate-only proposal to fund a compliance support grant for Chapter 144G providers. So this would be funded one time at a total of $420,000 in fiscal year 2025. $250,000 would be state government special revenue, and $170,000 would be general fund dollars. Moving next to line 520, this is a waiver request to federal nursing home staffing requirements that were put in place. This is included in the Senate position only and is budget neutral. Moving now to the Council on Disability, line 612, this would fund the establishment of a legislative task force on guardianship. This is included in the Senate position and funded one time in fiscal year 2025, $400,000.
And finally, Mr. Chair and members, on line 624, the House includes at the Department of Corrections costs related to the reducing recidivism, preventing overdose. That is the reentry waiver. That's funded at $1.649 million in 24-25 and an ongoing cost of $4.288 million. And Mr. Chair, that's the spreadsheet.
Mr. Berg, Mr. Raymond, thank you. Thank you for giving us that high level of what is in there. Any questions, members, for our fiscal wonder staff over there? Senator Abler.
So I'm sorry I had to take 2 calls, so I might have missed it, but Senator Hoffman, you mentioned that the Department of Health came up with like $3,000 or $4,000 for people, or somebody did, to move, like go from this place to that place. Is that in this bill somewhere?
There's the relocation.
Yeah, the relocation.
Yeah, there's there's when somebody with a waivered service needs to go, wants to move from apartment A to apartment B. Yeah, that's in here, Senator Abler. That piece is in there.
Oh, was that the provider thing that we're talking about?
Mr. Chair,
Mr. Chair.
if we're talking about the relocation,
Yeah.
the Senate provision was removed. We do have that provision in the House, but then the cost was not included on this spreadsheet.
And Mr. Chair?
Mr. Berg.
Chairman Noor is correct that that language is in the House. However, we were under the impression that that was cost neutral, and we have been contacted by both the Department of Human Services and the Department of Health that there are costs related to that language. Mr. Raymond and I have had a meeting with the Health Department to talk about it a little bit, and it's they're working on some information for us. It's a little more complicated than we initially thought.
So, Mr. Chair, Mr. Senator Abler, that relocation side of it for the 144G for the providers that you and Senator Fateh had started a couple years ago. Now I'm on the same page. That should be neutral, but apparently there's a cost to that. Is that what what you're
Do you want
getting
to talk about that now, or
We can. I mean, we're good.
come up and mention that, or I don't know what your schedule is like for today.
Mr. Chair, I just wanted to, first of all, follow the testifiers and thank the nonpartisan staff for their work. And I think there's some few other questions on the spreadsheet that we may ask them, but at least at this point, let's allow.
Well, Mr. Chair, I just wanted to offer some advice. So I made up a form that they could use. So a lot of these people, they already know them pretty well. And so, sometimes you have to pay to develop forms, you get a consultant, put out an RFP. So like, this is the form I suggest. And you like do a review, and then you just like just kind of like, check the box, and then you're good to go. So I'm trying to help. Thank you, Mr. Chair.
Mr. Chair. Senator Abel, I think we need to give everybody here say yes or no. They can raise on those issues, but I think we've got a long way to go, and we'll.
So, and I know, Senator Abel, you have a time commitment. All right, and Mr. Berg, thank you. No other questions for our two. That's great. And then let's move on. Leah Monahan and Danielle, Ms. Pinelli and Mr. Monahan, do you want to land this plane? Did you ever see that video Building an airplane while it's flying. I tried to show it last year when we were getting to the Y, and I couldn't get it to, yeah, remember that? I love that form. Is that the new Min Choice, is that the Min Choices 2.0, 2.05?
Mr. Chair, this could be used to have them, I can give this to the commissioner, and she can just hold us up on every good idea that we have. So, and then just do it. Anyway, thank you.
Mr. Monahan, Ms. Pinelli, thank you, welcome.
Mr. Chair and members, for the record, I'm Liam Monahan, analyst from Senate Council. We will be working through the comparison document, the short one with the table. Looks like this. We're just going to hit on the proposals that are in the bill. Some of this will be duplicative of what Mr. Berg and Mr. Raymond have already covered, but this will help you find the language in the bill if you're looking for it. I'm going to do Articles 1 and 2, and Ms. Pinelli is going to do the remainder. So starting with Senate Article 1 and House Article 1, the first group of sections, beginning with Senate Section 1 and House Section 1, are all related to eliminating parental fees for families when a child is living in a children's residential facility, a psychiatric residential treatment facility, a residential treatment facility, or an ICFDD. It also makes various conforming and technical changes, including moving the definition of related condition when that term is used in the expression developmental disability or related condition. Moving on to Senate Sections 4 and 5. This is a Senate-only position, establishing a temporarily available exception to the moratorium on licensing new community residential settings for certain facilities. Senate Section 6 is a Senate-only position, modifying the home and community-based services standards for out-of-home respite services for children. Senate Sections 12 and 13 are a Senate-only proposal. It's actually two separate proposals that we've grouped together here. The first requires the commissioner to give equal access to electronic visit verification system data to all electronic visit verification system vendors. And then the second proposal permits, in the current version, permits weekly electronic documentation of certain service visits when those visits are performed by a direct care professional who is providing services to someone who lives in the same home with the service provider. The next group of sections are House Sections 9, 12, 15, and 17. These sections require counties to periodically initiate a competitive proposal process for contracted case management services. Moving on to Senate Sections 14 and 16. These contain two provisions related to min-choice assessments. The first makes permanent an existing temporary exemption for certain assessments performed by contracted assessors. And the second proposal extends the timelines for responding to a request for an assessment. The next group of sections are identical. They're a governor's proposal, the Senate Sections 15 and 17 and House Sections 10 and 11. These modify experience requirements for certified min-choice assessors who are registered nurses, and also extends the validity of a min-choices assessment from 60 days to 365 days. House Section 14 is a House-only proposal modifying the EI-DBI provider qualifications. Next group of sections are Senate-only position, beginning with Senate Section 19, 43, and 45. These sections increase the transitional supports allowance from $3,000 to $4,114. I'll mention at this point that the repealer will look like it's repealing the transitional support language, but that's not actually what's happening. The program is not going away. It's just the waiver plans govern that program, and the language doesn't need to be in statute. Moving next to Senate Section 20, 21, and 33. These modify provisions related to the consumer-directed community supports option by increasing disclosure to participants, limiting lead agencies' discretion with respect to CDCS policy, and directing the commissioner to clarify certain policies regarding that program. Senate Section 22 modifies the rate encumbrance under DWRS to permit technology costs related to remote supports to be included within the required compensation cost encumbrances. Next are two different versions of a governor's proposal. Senate Section 26 matches up with House Section 22. The governor's proposal was to develop an MA benefit for hospital transitions. Mr. Raymond mentioned this. The Senate instead modified a prior request of the department to achieve the same proposal outcome. Senate Section 27 and 28 are Senate-only position, modifying eligible applicants and allowable uses under the Provider Capacity Grant for rural and underserved communities by allowing the grant funds to be used to assist providers determine the most appropriate license and program to best serve their targeted populations. Next, Senate Sections 29 and 30 are a Senate-only proposal modifying the definition of New Americans for the purposes of the New American Legal, Social Service, and Long-Term Care Workforce Grant Program that was enacted last year. Senate Section 31 is a Senate-only position establishing the Advisory Task Force on Family Residential Services. Senate Section 32 and House Section 25 are nearly the same except for technical differences. These sections permit lead agencies to establish assistive technology partnerships to facilitate timely authorization of allowable technology and assess the benefits of the use of technology under the HCBS waiver, among HCBS waiver recipients. Next is Senate Section 34. This is a Senate-only position. Directs the Commissioner of Human Services to draft legislative language to permit CFSS support workers to work up to 8 hours of overtime per week, to provide overnight staffing, and to work 80 consecutive hours. Next is Senate Section 35. This is a Senate-only position. Though it was a governor's proposal to permit the provision of unit-based waiver services under certain conditions in an acute care hospital. Senate Section 36 and House Section 25 are different approaches to requiring the commissioner to contract for a continuous improvement study regarding access to disability services. Senate Section 37 is a Senate-only position establishing a grant for certain home care providers to defray the cost of complying with the electronic visit verification requirements. Senate Section 38 is a Senate-only position establishing emergency relief grants for rural EIDBI providers. Senate Section 39 is a Senate-only position establishing the Legislative Task Force on Guardianship. Senate Section 40 and House Section 28 have technical differences, but both bodies establish the Own Home Services Provider Capacity Building Grant. Senate Section 41 and House Section 27 have technical differences, but both bodies establish the Pediatric Hospital-to-Home Transition Pilot Project. Senate Section 42 and House Section 26 are similar. Both bodies permit state-only funding for PCA services provided by parents and spouses beginning October 1, 2024, until the full implementation of CFSS. Senate Section 44 and House Section 24 are the same. It's a governor's proposal directing the commissioner to develop a tribal vulnerable adult developmental disability targeted case management service as a covered MA service. And finally, the repealers, I already mentioned those. They're related to the elimination of parental fees, as well as the repeal of the language related to transitional support allowances. Moving on to Article 2, which I promise is shorter. House Sections 1 and 5 are a House-only position, allowing assisted living facilities to relocate, and provides for a limited exception to the customized living moratorium and age limitations for those relocating facilities. House Section 2 is a House-only position modifying the requirements of assisted living correction orders. I'll note that this language was also in Senate File 4399 and was adopted in that conference committee. Moving on to Senate Sections 1 to 4 and House Section 3. There's actually two proposals in here. Senate Sections 1 to 3 modify the food code requirements for small assisted living facilities. And then Senate Section 4 and House Section 3 permit modified orientation and training requirements for employees who move between facilities owned or operated by the same entity. Senate Sections 5 and 6 are Senate-only position that require assisted living facilities to provide all staff with training related to de-escalation and mental illness. House Section 5 is a House-only proposal modifying the reassessment requirements of residents of assisted living facilities. Senate Sections 7 and 8 are a Senate-only position. They modify the caregivers of people with dementia respite grant program. Senate Sections 9 and 10 are a Senate-only position. This was a governor's proposal to permit transition planning in the alternative care program. Senate Section 11 is a Senate-only position. This section contains the property rate increases for 4 nursing homes. I'll mention at the top of page 6, there's a formatting error, so you should just cross out the first 2 rows. Senate Section 12 is a Senate-only position. It provides a property rate increase to a facility located in Minnetonka by using statutorily appropriated money dedicated to the nursing facility moratorium exception projects. House Sections 6, 10, and 12 are House-only position that expands the financially distressed nursing facility loan program to include other long-term care services and support providers. It removes the sunset date on the loan program. It converts the program to a revolving loan program, and it makes other conforming changes. Senate Sections 13 and 15 are Senate-only position. This was a governor's recommendation to establish elderly waiver budget and rate exceptions for high-need participants, and it requires the commissioner to propose EW reforms to address the needs of older adults with high support needs. Senate Section 12 matches up with House Sections 7 to 9 and 13. These are all related to the customized living rate floor. These positions are different. The Senate reduces the rate floor and removes future inflationary adjustments and removes the rate floor sunset, and the House follows the governor's recommendation to sunset the rate floor. House Section 11 is a House-only position that provides for PACE implementation. That concludes Article 2.
Thank you. Mr. Monahan, it's just like, we were wondering, there's all these dollar amounts and then also in your summary, so it was like joint, multitasking. Can you believe that? Senators in the House can multitask at the same time. So thank you for going through that. Ms. Pinelli.
Mr. Chair and members, I am going to run through Senate Article 3 and House Article 3, the Substance Use Disorder Services article. House Sections 1 and 20 are House only. Was a governor's proposal to remove the sunset on the opioid manufacturer fee. House Sections 2, 8, and 16 are House-only provisions, modifying provisions related to the Ombudsman for Mental Health and Developmental Disabilities by expanding duties to include complaints related to peer recovery support. House Sections 3 to 10 and 17 are a House-only proposal modifying peer recovery support services and establishing a peer recovery support services working group. Senate Section 1 is a Senate-only proposal that was originally a governor's proposal. It adds the director of the Office of Addiction and Recovery to the Opiate Epidemic Response Advisory Council as a non-voting member. Senate Section 2 and House Section 11 are a governor's proposal. It modifies the Opiate Response Fund allocation and allowable uses. House Sections 12, 13, 18, and 19 are all House-only sections related to establishing a reentry demonstration waiver under medical assistance. House Section 14 is a House-only proposal providing for a 3% rate increase for SUD services. And House Section 15 is a House-only proposal providing for carry-forward authority for Project ECHO. Mr. Chair and members, the next article is Senate Article 4 and House Article 4, the Priority Admissions and Civil Commitment article. House Sections 1 and 3 are a House-only proposal modifying requirements for locked IRTS facilities and removing a fiscal year 2024 appropriation for those same facilities. Senate Sections 1, 5, and 7, and House Sections 2 and 7 are both related to modifying the priority admission standards for patients being admitted to DCT programs from jails and correctional institutions, requiring exceptions to the priority given to patients in jails and correctional institutions, and establishing a priority admissions review board. These two proposals are different. The priority frameworks are different and apply to different populations. The House has a pre-admissions notice required and the Senate does not, and the priority admissions review panel duties are different. Senate Section 2 is a Senate-only provision. It prohibits the closure of or modification of the population served by the Community Addiction Recovery Enterprise Program in Carlton. I'll just note the House has the same proposal. It's just we don't have this section of language. It's just accomplished on the spreadsheet. Senate Section 3 and House Section 4 are both related to reimbursing specific counties for certain cost of care payments. They're different. The Senate includes both Beltrami and Todd counties, and the House includes only Beltrami County. Senate Section 4 and House Section 6 establish an engagement services pilot program. These are similar. The Senate limits this grant program to only Otter Tail County, and the House allows the grants to go out to any county or any CCBHC. And the House also requires the engagement services to provide culturally responsive early interventions, and the Senate does not. Senate Section 6 and House Section 5 are both related to establishing a civil commitment reform task force. These are the same except for the membership of the task force. The House includes 2 additional task force members. And finally, in Article 4, House Section 8 is a House-only section that establishes a county correctional facility mental health medication pilot program. And next is Senate Article 5 and House Article 5 related to direct care and treatment. Both of these articles, the House and Senate articles, are quite similar. They both establish direct care and treatment as a separate agency, specify the organization and requirements of the executive board, and specify the powers and duties of the chief executive officer. The differences between the House and Senate are that the Senate has the governor appoint the chief executive officer, and the House has the executive board appoint the chief executive officer. The House classifies the chief executive officer as an unclassified position, and the Senate does not. The House allows for this new agency to have expedited rulemaking authority until July 1st of 2027, and the Senate allows that rulemaking authority until July 1st of 2030. The House includes 9 members on the executive board, and the Senate includes 10 members on the executive board. The Senate designates the chief executive officer as the chair of the executive board, and the House does not. And finally, the Senate vests certain powers of the board exclusively in the chair of the board, and the House does not. The next article is Senate Article 6 and House Article 7, the miscellaneous article. House Sections 1, 6, and 7 are House only. These sections establish an Office of Homelessness and Housing Support in DHS and a working group on simplifying supportive housing services. House Section 2 is a House-only provision, requires the Interagency Council on Homelessness to annually report certain homelessness data. Senate Section 1 is a Senate-only provision requiring DCT to provide free communication under specified conditions to patients and clients of certain state-operated treatment programs. Senate Section 2 is a Senate-only provision establishing a planning grant for implementation of a community care hub. Senate Section 3 is a Senate-only provision directing the Commissioner of Health to seek a federal waiver to the new minimum nursing facility nurse staffing requirements. House Section 3 is a House-only provision. It requires the commissioner to consult with others on targeted case management redesign. House Section 4 is a House-only provision. It requires the commissioner to develop a health-related social needs waiver. And finally, House Section 5 is a House-only provision requiring the commissioner to study navigator reimbursement. The next article is Senate Article 7, technical corrections. The House does not have a similar article, but we've got similar provisions in other articles within the bill. Senate Section 1 and House Article 8, Section 4 are the same. They extend the carry-forward authority of the appropriation for the financially distressed nursing facility loan program. Senate Section 2 and House Article 1, Section 20 are the same. They extend by 1 year the due date of an evaluation report related to the Direct Care Service Corps pilot project. The House also has an additional section related to this that modifies the rider language. Senate Section 3 and House Article 8, Section 5, both relate to aligning the effective date of the new rates for SUD treatment services with medications for opioid use disorder to align with the 2023 spreadsheet, but the House and the Senate have different effective dates. The Senate's is January 1st of 2025, and the House is January 1st of 2026. And then finally, Mr. Chair, the last article is a House-only article that creates a Human Services Response Contingency Account in the Special Revenue Fund of the State Treasury.
Wow, thank you. Mr. Monahan, Ms. Pinelli, thank you. I love when you're going through this summary, it's getting dialogue up here about, because there's clearly some differences, and we got some work to do that, but I appreciate you highlighting that. Members, any questions for? Thank you, you two. You're awesome. I appreciate that. So, members, if you look, let's get the commissioner up here. Jody, I think Ms. Harmstead, if you want to come on up. We got some timeline stuff. I'm going to move the agenda around. After Commissioner Harmstead is done having a conversation, I want to move us into the conversation on the disproportionate share. And the folks I have as wanting to testify in that, you had Lindsay Schmidt and Tim Funkmeyer, and I think Aaron or Angela, you also wanted to get something. If anybody else, if I'm missing somebody, you got to let me know. But I'm going to move that agenda item around. If you guys, everybody okay with that? We're good with that? All right, seeing none. Commissioner, welcome.
Thank you very much, Chair Hoffman, Chair Knorr, members of the committee. Thank you all for your efforts this session to improve the lives of people with disabilities, older adults, people living with substance use disorders, and all Minnesotans who need the support of our state human services system. I'm very pleased to see that both the House and Senate budget proposals build on the historic and generational investments in Minnesota's human service system, and even though we're in a non-budget session, makes important and critical improvements that will improve people's lives. I'm especially grateful for the inclusion of several of the governor's key supplemental budget priorities in both budget proposals, including addressing urgent need for psychiatric treatment beds with direct care and treatment, and key recommendations from the Priority Admissions Task Force. Additional funding to build on the success of bridging benefits to support people successfully reentering the community following prison. I'm also grateful for the Senate for including the investments and reforms to improve how we address acute care transitions and responding to the crisis of people boarding in hospitals and emergency departments. I'm similarly grateful to the House for including the Medicaid 1115 reentry demonstration project. As conference committee continues, we also ask that you include funding for the Human Services Contingency Account so that the department's well positioned to respond to unexpected and urgent issues that arise. We have a few outstanding issues we'd like to see resolved as we get further along, but in the interest of time, I'll wrap up my comments for today. Thank you again for all your work. I look forward to further discussion as we move to the end of session.
Thank you so much, Commissioner. I think we have a lot of things to do in the next few days before end of session. We look forward to working with you. I know we wanted to dive into the disproportionate share, which is a huge difference in the House and the Senate. I don't know if you wanted to comment to begin with, or anyone from DHS wanted to make the statement on the disproportionate share.
I think you've seen the position that we have in the proposals, and we'll just stand with that.
Mr. Chair.
I think Director Bailey wanted just to address that issue.
Okay.
Yeah. So I have a question after all that then, so I'll just wait.
Senator. Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Chair Nora, and hello, committee. I am Elise Bailey, Budget Director for the Department of Human Services. Are you, sorry, I missed the initial question. Are you
The
looking?
question is, there's a significant difference between the House and the Senate and the position of the governor. And I think we wanted to know what is the differences. You know, we funded 45% in the elderly waiver last year with the intent that we discontinue the disproportionate share. Can you please help us understand that issue?
Sure. Thank you, Chair Nora. Thanks for clarifying that. Yes, so the governor's position, along with the House, sunsets the disproportionate share program in January of 2025. The disproportionate share program was put into place at a time where the elderly waiver rates were quite low. And the intention was to have a minimum rate for those providers that have a high proportion of their residents on the elderly waiver or Medicaid waiver programs. But that the initial language would sunset that program once the rates were fully phased in, which thankfully the work of this committee had done last year. We did phase in those rates, and the rate increase, as you mentioned, was 45% on average across all customized living rates. But because there was a cross-reference error, the department felt like we didn't have legal authority to discontinue the program, hence the proposal. So the differences are that we are sunsetting the proposal in the governor's position in the House, and that the Senate is, rather than sunsetting it, is holding it flat at, I believe, $141 a day. We've done a lot of analysis on what would be the impact to providers by sunsetting the program. And we've pulled all of the data across all of the providers and looking at the increases that they got January 2024, even removing the floor, that around 45% rate increase would, they would still receive a difference of rates between 2023 and 2024. Even if we removed that rate floor, the aggregate impact to the provider would range between an increase of 39% increase in their revenue to 44.78% increase in their revenue, because only some of their residents get this rate floor, right? And so that would be the impact. Because we've kept it, the average rate increase is, I think, around 68% for these providers. We also think that there's some, by keeping it, we're not fully paying, or we're not paying appropriately for the services that are provided to folks, and maybe incentivizing providers to serve people who are lower needs, or having some sort of strange incentives for serving people on one program versus another. And so those are some of the reasons why we came forward with the governor's proposal.
Senator Abler.
Well, thanks, and we have these discussions, and I appreciate your explanation, and I think maybe it does make sense to change it, but to get rid of it, I think you're going to need some of that contingency money just to keep these places open and have some of these elderly people living in their cars, which I don't think is the position of the governor or the department. And so it needs a reform makes sense, and abolition does not. I think as we listen to the Delwood Gardens folks and some other people that are actually doing this, I want you to remember that where it kicks in is people with very high percentages of elderly waiver. I mean, this is not like, gee, you knew that. But so what is that like on the day-to-day? You give a provider who's got 2%, which is one of my great places in Ramsey that I thought, which provoked this whole discussion, 2 out of 100 after they spend down to poverty, and then they let them stay for those 2 people. Well, those 2 people are getting a nice bump. but they don't need the money. They have all this market rate stuff. The people who are doing the people that qualify don't have high market rate people because they have all these people that we've decided we're going to serve. So the impact on them is truly disproportionate when you just whack the whole program. And I think Senator Hoffman sat down with some people and came up with a really good plan that I think makes an honorable compromise. And so instead of saving $10 million, $10.3 million, you save about $7 million, which I think accomplishes the goal and doesn't cause the harm. And we'll listen to the testimony, but I just think that having it all go away is just a really bad idea, policy-wise. And the impact, I think, where they're actually kind of getting healthy and other places might want to take a higher percentage if they actually can stay open. I'll leave it at that, Mr. Chair, but I just urge you to listen to the testimony with the most open ear you've ever had and decide that maybe a really honorable compromise, cutting it by 2/3, makes much more sense than just zeroing it out. So thanks, Mr. Chair.
Thank you,
Commissioner, do you want to react to that at all? Or?
Elise, Commissioner?
No, I appreciate excuse me, Mr. Chair, I appreciate the anecdote and the possibility of differing impacts on different providers. So appreciate hearing that as we think about it.
Thank you. I appreciate you hearing the committee's concerns about which way to go, and appreciate you having Ms. Bailey on your team because her numbers are pretty accurate all the time. So Ms. Bailey, any response?
Yeah, Mr. Chair, thank you, Senator Abler. I hear from providers, but what I don't get is the math. Like when I ask my staff, let's pull it by every single provider and look at their aggregate impact, I'm not seeing where there's losses. I'm only seeing gains between 2023 and 2024, even if we take this out. So that's kind of where I'm questioning if we set the floor, and it's only been in existence for 2 years, and we set it at an amount that the providers feel like was an amount that they felt was financially viable. And when I look at the data now and we're removing it, they still have a 44.78% average increase between 1 year and the next. That's what I'm not getting. Why is it not viable at this point when we increase the elderly waiver rates to such an extent?
Senator?
Mr. Chair, so maybe it's time for testimony.
Yeah.
Because I think that, what would it be like, Mr. Chair, and to the department, what if we had places that were actually operationally healthy and could actually serve these individuals in a way where they had enough staff and they had good food and they had a life that they can be proud of? And so I think the state programs that we set up, particularly for this where it's all dependent on the state and the feds, people have spent on the poverty or whatever, what if they had a good life? And otherwise they have to retrench, and then they'll like be these, not nice places. So, Mr. Chair, thank you. And I know the 2 people in the world who care are sitting at this table, so I'm giving you that. So thanks, Mr. Chair.
Thank you, too. With that, Mr. Chair, we want to bring Lindsay Schmidt. Tim Funkmeyer, I see you scratched, so Aaron and Angela, that's a no to you, too, on any confidence. So Lindsay Schmidt, you want to come on up, and Tim,
Thank you very much.
welcome to the committee. For the record, state your name.
My name is Lindsay Schmidt.
Thank you, Ms. Schmidt. You may proceed.
Thank you. Good afternoon, Chairperson Noor and members of the Health and Human Services Conference Committee. My name is Lindsay Schmidt, and I'm the Licensed Assisted Living Director with Dellwood Gardens Assisted Living and Memory Care in St. Paul. I'm here with my colleague and owner, Tim Funkmeyer. Dellwood Gardens is a 101-unit assisted living and memory care community who serve predominantly individuals on the elderly waiver and caddy programs. We are here today to ask that the disproportionate share program be retained to ensure the most vulnerable adults that need assisted living services have the funding available to do so. The disproportionate share program is a vital program for elderly waiver residents who face higher care needs that cannot be met in the community. There are 27 assisted living facilities serving approximately 900 individuals in the state of Minnesota. The current rate floor is approximately $190 per day. The Senate proposal that is included in SF 5335 includes a reduced floor rate of $141 per day. If the disproportionate share program cannot be retained fully, we support the rate floor increase of $141 per day, but would recommend no changes to the disproportionate share program until we see the full effects of the updated EW rates. In terms of why we support and request the continuation of the disproportionate share program, we would like you to know a bit more about the types of support we provide to a diverse urban St. Paul community. Those served through the disproportionate share program have unique and sometimes challenging needs, both behavioral and social, that require specialized and extra staffing to meet their needs. The loss of this funding will remove the ability to provide proper person-centered services and care. If the disproportionate share program is eliminated, it will make it more difficult for low physical acuity residents on medical assistance elderly waiver to find assisted living communities to meet their needs, as providers will increase their minimum criteria for admission. Even with a 44.8% average rate increase, certain residents' base daily rate will be below $100 per day, a figure that makes meeting all care needs for providers unattainable. This will cause a greater burden for the individuals needing assisted living services on elderly waiver, their families, and county case managers. These are individuals who are often coming from untenable living situations, often homelessness, but have found a home in our assisted living communities. And please let me be clear, while these residents' physical acuity needs may be low, their behavioral care needs are high, creating more need for case management supports within the assisted living community. The care we need to be able to provide for these residents demands additional staff time and additional wages to hire and retain good talent. We are very grateful to the work that you are doing in the community and the rate floors. And we ask that the committee allow continuation of the disproportionate share program, and we thank you for all the work you're doing for our most vulnerable adults.
Thank you, Ms. Schmidt. So, Mr. Funkmeyer, help us. I know the work. I've seen the work that in lots of the facilities that you operate, and this was always one of those moments where you go, all right. Right. And we know, Senator Abler, when you, I don't know the year, 2017, 2019, those seem come to play. You know, there's going to be a time when we don't need it anymore. And last year we raised elderly waiver rates 45%. And hearing Ms. Bailey talk about the 39% across the board, you know, what are you seeing? You know, as a follow along, what are you seeing, and what do you feel the direction is that, in your opinion, as somebody in the ground, in the trenches doing that, just so we can have this information for next week? Right. Is that a fair question?
It's a fair question. Good afternoon, Chairperson Noor and members of the committee. Grateful for your time.
I want to correct these guys, because I know, this is funny. We're in the Senate here. I'm the chair of this committee right now.
Oh my gosh. Well, all right.
I'm glad. So you go back.
I'm following others.
I'm kidding, Tim. Go ahead. I just had, there's an opportunity for me to have a little bit of joy, because now I get the first time, but the second time it's like.
The Senate has good feelings, so don't worry about it.
Oh, okay. Right. No, go ahead, Tim. Help us understand from your expertise, which is huge.
And Lindsay, thanks, did a great job recapping kind of our story. And I would say a couple of things. One is that we have been on this journey of trying to make sense of even what the DHS analysis was from several months ago. And just as a quick example, DHS's report said that 89% of the elderly waiver rates with the, I'm going to be really clear about this, the average the cap increase on the case mix rates is 44.78%. The service rates are not going up by an average of 44.78%. It's the nuance, it's the detail of this program. So and if we need to take a minute on that, I'm happy to do a little back and forth on that. But the rates didn't go up by an average of 44.78%. The case mix cap by case mix type went up by an average of 44.78%. And I'm happy to, if there's somebody who disagrees with that, I'd be happy to hear that.
What this committee asked was from your perspective, and I'm looking for Ms. Bailey to kind of not, when she, is looking at this, because we're going to be doing something next week, and it's really going to be, that expertise there. So Senator Noor, since you're in the Senate.
That's a demotion if I become a senator. I think there's been some discussion on this issue, if Director Bailey can really clarify on that based on the case mix versus the individual services, because that's a really important conversation to have.
Great.
So, thank you, Chair Noor. The essence of that case mix versus rate conversation, let's just stay there, let's stay focused there. Help us understand from your perspective.
Chair Noor, Senator and representatives. The case mix, the increase to the case mix is reflective of the increase to the rates. So we increase the rates as the legislature requires in the law, and then we increase the case mix accordingly so that people can buy the same amount of services they did previously.
Yeah, and I think the additional point here, though, is that the service rates by service type have the increases over them vary widely. Meal preparation, for instance, went up by 78%. It's an extraordinary amount. It was, I presume what happened was that there was a study of the market correctness of the rates, and this is the 2017 waiver reimagined. It goes back a ways. But in our own experience, we have two buildings that are predominantly elderly waiver and caddy that serve close to 200 people in Minneapolis and St. Paul. And our one building is only seeing with the 2024 EW rates, they're not disproportionate share, is somewhere in the 11 or 12% increase. It's an interesting matter. At Delwood, it's sitting in that 40%, 45% range. So the point is, it's varying widely by provider, and it's probably a lot of why we're asking for some kind of careful consideration of where this goes. In fact, are we really at the point where we know the full impact of the 2024 EW rates when providers are spending the entirety of this year to either assess or reassess residents so we get the new rates? We still, rough numbers, we're a third into this year, only a third of the residents are on the new EW rates in non-disproportionate share facilities. So my point is, we don't really know the full impact of the revenue increase at this point. It's estimated, it's speculated, it's not calculated.
Chair Noor.
Thank you, Mr. Chair. So the key question is, do we need one-time only off-ramp process, or do we need to go back to the original disproportionate share and exclude that group from the increases that we made, if that is the right path to go?
So take that and think about that question. Actually is a pretty, it'd be nice to hear what would that mean for the impact of the system? And that's something maybe you two could, do you want to go first, Ms. Bailey, or do you have a response to that? I mean, did that make sense, that question, or is it something you want to ponder? If not, it looked like Mr. Funkmeister did.
To clarify the Chair, to clarify the question is keep the disproportionate share, but not apply the 45% rate increase.
That's correct, Mr. Chair.
Senator Abler.
Chair Noor, Senator Hoffman. I get so confused. It seems as though the posit from the department is they got a lot of money, they should be fine. The commissioner's back there somewhere, and every so often they bring a request like this in the last session. They got a bunch of money for new staff, like a lot of money. Well, if you recall the discussions with the predecessor of on the health side, who who's now in the hallway, and I agreed with her sometimes, gee, that's a lot of money. Let's give them a little less money so they can be fine. It's still a lot of money, but you say, we can't hire all the positions we need. It's a lot of money. And so just because they're getting a lot of money doesn't mean that it's not money that was really a good idea. I urge you to go visit that place. They actually have clean floors, good food, happy clients, and they have staff who actually cares about the people, and they stick around. Isn't that the model we're looking for? Oh no, Mr. Chair, I think it would be better if we could have staff turnover twice a year and have people who are untrained, uncaring, and have food that just barely meets the minimum health standards.
So,
It would be legal, Mr. President, but Mr. Chair. But so I don't think we want that, and I'm just going to push the department in the most friendly way I can push. And I do have a new form for you that you can use that might help you along the way with this here.
It's just funny.
And so I think the answer isn't to take away the rate increases. The answer is to maybe phase this and go with, I think the answer the Senate's come up with is a reasonable intermediate state. Next year is going to be, well, that place where you go if you're really bad on earth. It's going to be really tough next year because there's going to be shortfalls.
Yep.
And so I don't think we want to send this group, the people that have gone out of their way to serve the people that have the most challenging economic states and high needs, to go into that fairly open. And if we need to adjust it next year after we do this version, that makes sense, and then maybe there's a small savings you can get to handle I sat through a $6 billion deficit, and we came up with a budget that was 1.8635 reduction, and settled for $1 billion with Governor Dayton this time. It was horrible.
No, that's not what they're
So
saying.
let's go in, let them stay strong, and please review the Senate position, which I think is just really sound. And above all, do no harm. Thank you, Mr. Chair.
Thank you, Senator Abler. I think Representative Noor, a couple of things. You said that the rate, don't take the rate increase, do the rate increase, do we need to revisit kind of thing. Where Senator Abler, as we're talking, and I know we're not negotiating, but we needed to have this dialogue because I am still not convinced on either side, right? But what I do care about, the most vulnerable people that need a place to live, right? And that they're not being forced, and I know this isn't happening in your places, Mr. Funkmeyer, but I'm hearing anecdotal stories of, well, convert them from, Caddy BI over to EW, right? Mm-hmm. Based upon what we did last year. And hearing that, I start to then, and I've talked to Ms. Bailey about that's always been my primary filter. But just hearing this dialogue is I'm still as confused as I was the minute I walked in here. Mm-hmm. Now you get to the point on during the COVID. How was COVID in when you look at Delwood? You talk about a place, Senator Ayler, it's really good. You guys had it under control. I mean, you had that under control because of the quality of care that's there. I mean, unbelievable, right? I knew that for a fact because that report came back. But this conversation we're not over with this. I mean, this is really, I think, going to hold us up for some deeper conversation. So is there information you can help me get unconfused on, other than the fact that this is the Senate, and I have the gavel, so it's, Chair Hoffman, and then,
Chair Hoffman.
That's all I know today.
Representative Noor. Yes, I would like to kind of speak to what Senator Abler just said, in that our proposal isn't really about too much money. It's about making sure that we pay for services in a way that, reflects the needs of people and reflects the services that are provided to them. And this is a rare instance where we actually have a provider-centered rate structure versus a person-centered rate structure. What do they need? And how are those services being provided? And that's where we're coming from. In this instance, we set what the provider, what services are needed for the person, and then we say, but let's pay the rate way up here at the same amount that maybe a higher level person needs. So that's kind of where we're coming from, in that now that we've phased in these rates, We've increased it by 45%. None of the rates went up by only 11 in the elderly waiver program. The only instance of that occurring is if they were reassessed and they're getting less units of service or something like that. But if they're the elderly waiver program, and if it was the same level of service that they got last year, it would go up by that amount. So that's kind of where we're coming from, is making sure that we have a system that incentivizes, rates that appropriately pay for the services, and that higher needs folks are taken by these wonderful providers as well as low needs folks. So that's kind of what
We're going to go Senator Abler and then Senator Representative Noor.
And thanks, and this will be my last comment. I appreciate the discussion, but just as I've listened to the discussion along, you persuaded me that 189 is probably too high. So here we are at 141. That's quite a reduction. And so the discussion like, gee, they're getting so much money at that high rate. Look, I think you persuaded the people at this table that that old way is not a good way. But I'm hoping you can be persuaded that transitioning, that taking 2/3 of the savings and seeing how it all levels out is a way that makes some sense to keep the good things going and to draw people into wanting to serve higher numbers of elderly waiver and take a risk. Because I can tell you, if I'm thinking about going above 50, 60% with this discussion, I'm not doing it. And you're going to find that we don't have places to put folks that are in this level, and you have all these people, like Mila, the one that provoked me, doing 2. And so I just want to, please think about it. And I mean, the Senate is 70% of the way to your proposal. And I think there's a soft landing place. And I'm only going to remind you of one thing, and then I'm going to stop both chairs. If you recall, there was a proposal a couple years ago to reduce NEMT rates by 50% based upon Colorado's rate. And the governor had it and the House adopted it, the other body. And I said, that's not going to make sense. And so we argued about it and we didn't do it. It turns out that wouldn't have worked at all. And in fact, we needed to raise the rates even above what they were, and they're still not giving rides to people. And so you can't, this is not disparaging anybody there, but you can't know everything. You can't understand the impact of what this might be based upon a model that seems like it's reasonable. And so maybe the providers who are doing these high percentages would be helpful. I saw one chart that shows there's a significant loss, which I think would be incrementally damaging to the program between the abolition and the 141. So maybe if you can provide documentation like that just to persuade, particularly Chair Noor about this. That wasn't a joke. It's just, he's a chair in his own right, Mr. Chair. But I think that's the thing. And so it's tempting to oh, here's $3 more million. You could go buy something else. I just caution us about that. And I do appreciate the dialogue, and Commissioner, thank you for that. And, I know you care. And so I think if we can examine a model that's actually working, maybe that could be our base. A working model here that we can function with. Thank you to both chairs.
No, I think you and going to Representative Noor, I think you two are on the same discussion, same pivot. It's just how we get there is going to be a little bit different. So, Representative Noor.
Mr. Chair, I think the other bodies here physically present here today. Just joking about it. I think this is an important conversation. I think we need to roll our sleeves and come to consensus of what is the right and appropriate rate for the disproportionate share, and also looking into what happens if you've got CADI and BI folks, because we are saying you have to have 83.5% customized living, and also 70% of the residents have to be on elderly waiver. What happens if you get some, clients who are in CADI and BI? Where do they go to? Because you have got that threshold. Are they allowed to stay, or you have to find other places for them? Are we going to ignore their needs in that area when it comes to folks who are taking care of disproportionate share?
So is your question about if the program were to go away, and then what would happen with people on the program if disproportionate share didn't provide those requirements for 70% elderly waiver, 83.5
Correct.
24-hour customized living. I mean, you know, today I can only speak to our business model.
Mr. Funkmeyer,
Yes.
before you talk, because this is still recorded, and please wait for me to say, and then just make sure you say, you know, Tim Funkmeyer from
I will, thank you.
Minneapolis.
Tim Funkmeyer, Delwood Gardens, St. Paul, Minnesota. And I can speak anecdotally, but I know my provider colleagues would likely share this opinion. If we are predominantly, as we have been since we opened in 2014, serving elderly waiver and caddy, we're not going to make a change to our criteria about continued stay in our setting as a result of any change in their payment source, if that's the question you were asking.
Mr. Chair, just to get the clarity, you know, because we are centering disproportionate share based on the number of people who are receiving elderly waiver in that setting. Let's say you've got CADI and BI individuals who need care at the same time. You end up having 69% rather than the 70%. With this process, as we're talking about the rate increase of the 45%, we're ensuring that it's more inclusive. Are you going to be able to say, I will not continue with this because you don't qualify at that point for the disproportionate share? Or how do we proceed to make sure that every individual who has good needs, because it's a more person-centered rather than just provider-centered, as we just had from Director Bailey?
Mr. Funkmeyer?
I think it's a reiteration of what I said a moment ago. It's just that we would not see if a provider like we have made the decision to serve, and this has been from day one. This was not a business decision that was made after we opened in 2014. And so I would always, we've never had that conversation. I can't see pivoting to a different business model. It's the business we're in, and again, you're probably receiving more anecdotal. I don't know how helpful that is, but that is my response.
Mr. Representative Noor.
Thank you, Mr. Chair. I think I appreciate the dialogue and the conversation. This will continue until we have got something settled by at the beginning of next week. Thank you, Mr. Chair.
Thank you. Any follow-up questions, folks? Thank you very much for doing it. Thank you, Ms. Bailey, for bringing your laptop and spreadsheet isms. I like that. Thank you. Let's go to the top. Brian Zerbis from March, and then Cameo Zender, and we got three chairs up there, so let's get Tanner Fritzinger as well. You three want to come on up? Come on down. You're the next on. Name the chair in this committee.
Thank you, Mr. Chair. Committee members, Brian Zerbis from the Minnesota Association of Resources for Recovery and Chemical Health. First, I want to express our gratitude for the authors of March's funding proposals. We're very appreciative of the dialogue that we've had through committees, particularly Representative Baker and Chair Noor in adopting the 3% increase for STD rates. We request that the conferees adopt the following provisions from the House language. In Section 12, regarding the reentry waiver, specifically March is very pleased that we're including the reentry work group. Section 14 is the inclusion of the 3% rate increase for SUD. Section 17, again, the peer recovery support working group, March is pleased to be included in that work group as well. And in Section 19, the 1115 reentry waiver, we see as a huge benefit to people leaving incarceration. We appreciate the opportunity to work with DHS, particularly Christy Grom and her team have been wonderful to work with, and bill authors on other sections in the bill around peer recovery support services. Lastly, to underscore that not new information, overdose death rates are at an all-time high. Program closures, net closures, 45 net programs have closed in the last 2 years, and staff are burned out, according to a survey we conducted with more than 620 workers in the state. The recent outpatient rate study completed by Burns & Associates identified that STD rates are well below the cost of delivering services. The average increase needed for all STD rates is around 68%. The re-inclusion of SUD and the 3% increase is small, but a meaningful step for SUD programs. The support and attention you've shown to SUD programs will provide a ray of hope to those providers. In closing, I want to thank you all for support and the work that we've had up to this point in session.
Thank you, Ms. Serves. And, you know, thank you for the shout out. And when it comes to that behavioral health part, yeah, Christy Grom is absolutely the go-to person at the department, Brian, and I appreciate you knowing that, seeing the good work that she does. She's been a great TA provider to all of us here in this committee, and I thank you for pointing that out. Cameo Zender, welcome.
Thank you, Chair Hoffman and members of the committee. My name is Cameo Zender, and I'm with Pediatric Home Service, and I'm speaking here today in regard to the Pediatric Hospital to Home Care Nursing Pilot Program. We were and are immensely grateful to see this in both the House and Senate proposals, and we ask for your continued support so we can get medically complex kids home faster and keep them home longer. We will be absolutely delighted if we have the opportunity to come back and share a report that will prove the positive difference we can make for hospitals, to healthcare costs, and most importantly, to our children and their families when we invest in the outstanding nurses that care for them. Thank you again for your support.
Thank you, Ms. Zender. Before Tanner starts, then Aaron and Angela, do you want to come up as well and come up front? Tanner Fritzinger, welcome.
Yes, thank you, Mr. Chair and members. My name is Tanner Fritzinger, and I'm the Political Affairs Coordinator for the Minnesota Association of Professional Employees. First, we appreciate the time members have taken to meet with workers from Care Carleton and Care St. Peter. Additionally, I want to thank both bodies for their commitment to keeping Care Carleton open. However, we are still concerned with the plans to close Care St. Peter and what that decision could entail. Care St. Peter is a residential facility, not one equipped with the proper security to ensure the safety of staff, patients, or the surrounding community. Opening more beds in a non-secure unit could force staff to fast-track the discharge of patients who have not had their risk factors properly addressed. This could pose great safety risks for the community. With the current lack of staff and operational bed capacity, the forensics program often looks at not who is ready for discharge or lower intensity placement, but who is most ready. The staffing issues facing Care St. Peter would only be exacerbated with the transfer of 16 additional beds to forensics. The facility currently has 2 entire forensics units offline due to the inability to staff them. Additionally, asking care staff who currently work with chemically dependent people to take jobs offered to them in forensics working with clients who have been civilly committed as mentally ill and dangerous is a drastic change in their casework. Again, thank you for the progress that has been made to keep Care Carleton open. We know that this is not a budget year, but we hope that the committee will consider prohibiting any further closures of direct care and treatment facilities until after the new board and chief executive officer have assumed their management of the new agency and can review our care system more holistically.
Thank you, Ms. Fritzinger. Thank you very much. Representative Newer, I had the part of that, it just dawned on me, right, that now St. Peter is in that same, the CARES, it's that CARES, I mean, where else do we do those kinds of programs in the state of Minnesota? I'm not happy to hear that that's part of that piece, that we left that. When we went to protect Carleton, we didn't realize that in order to make beds, this has now dawned on me just what that really meant, that impact. And so any thoughts about what we want to do? We're going to have the discussion more on that, but I appreciate Tanner for highlighting that.
Mr. Chair, I think there's no closure for the St. Peter. It's just, suspending it and then creating forensic. That's the conversation we're having, and that's something which has been presented to us.
Thank you. I appreciate that. Ms. Hubert and Angela, Ms. Guerin, welcome to the committee. And then Ms. Radina, do you want to come on down, Parachai? Are you here? There you are. Come on. Go ahead. Who's going first?
Chair Hoffman. And
Thank you.
And members of the conference committee. For the record, I'm Angela Guerin with Care Providers of Minnesota, here today on behalf of the Long-Term Care Imperative. We have submitted a letter outlining our support for a number of provisions in either the House or the Senate position. But for the sake of today's testimony, my colleague and I would like to focus our remarks on a provision that's currently in neither. That is avoiding a December fiscal cliff for nursing homes by extending the temporary rate add-on of $12.35 per day. We may never know how many nursing homes you saved from closing following the end of session deal last year that brought $300 million in one-time nursing home funding, but we heard from a number of individual providers expressing their extraordinary relief. In January of this year, we surveyed our respective members, nursing home provider members, about how they were doing. The data was very clear. Occupancy and finances are showing promising signs of recovery. Nursing home occupancy is inching closer and closer to pre-pandemic levels, with the state average occupancy hitting 81.9% by the end of 2023. Limiting census due to staffing is becoming less common statewide, but especially here in the metro. It's down from 71% in Q4 of 2022 to 36.8% in Q4 of 2023. In that same survey, we asked how our nursing home providers used that $12.35 rate add-on. And while providers could select more than one response, the most common responses were that 59% addressed operating deficits. 50% increased employee wages, even though they would have a 6-month unfunded gap on top of that 21-month delay. The other two uses of the $300 million investment last year of one-time money were used for employee bonuses and restructuring long-term debt. Those were used as intended by the legislature. The results of this survey make it clear. When the legislature provides funding, nursing homes, staff, and access to care stabilize. I'd like to turn it over to my colleague. Thank you.
Thank you, Ms. Shepard. For the record, please state your name.
Thank you, members of the committee, Chair Hoffman, Keeper of the Gavel, Chair Noor, members of the conference committee. For the record, my name is Erin Hupert with Leading Age Minnesota here on behalf of the Long-Term Care Imperative. As this committee is fully familiar, nursing homes have, as a result of their cost-based system, a substantial 21-month delay in receiving their rates. That ultimately means that a provider must use yesterday's funds to pay for today's expenses. And it also means that it's nearly impossible to pay for tomorrow's obligations without using reserves, extending lines of credit, or deferring payment of other needs. And so I bring this up because within the last month, a number of nursing home mandates beyond the eyes of this legislature have put some spending obligations in motion that nursing homes and the state itself will be very challenged to afford. The first, which is due to be effective before the next legislative session even convenes, will require nursing homes to pay time and a half for more holidays than many nursing homes currently offer, and on a schedule that does not fully take into account religious, local, or historical holidays already provided for. It is important to be clear that this isn't about the substance of providing holiday pay for workers. It is about the financial means to be able to do so. Again, because of that 21-month delay, providers will need to produce funding this year to cover a new expense that won't be reflected in their rates until 2026. The next mandate will be to increase the pay of certain workers, again without upfront funding from the legislature. The board that is pushing this mandate forward believes it will cost about $9 million a year. In truth, expenses are much closer to $50 million a year. And then the last mandate will come probably 3 years from now, but due to its impact, we can't waste a moment in preparing because it will require finding hundreds more RNs to work in Minnesota nursing homes, when according to DEED, we are already 5,000 RNs short across the healthcare system. So in closing, we come before this committee and the legislature to appeal that you find a way to extend that $12.35 rate add-on. Our members started this year with hope and recovery. They see a fiscal cliff and several extremely expensive mandates on the horizon, and they are really fearful about how they're going to make it work. It is partially why you saw perhaps around 600 constituent contacts to the state representatives on Monday in advance of your Human Services vote on the floor. Thank you very much for hearing our testimony today.
Thank you, Ms. Shepard, for your testimony. Thank you, you too. Paul Verrett. If I pronounced your last name wrong, blame it on Chair Noor. Sophia Thompson, come on up. Ms. Radina, welcome to the committee.
Thank you, Chair Hoffman, committee members. I'm Pariche Rudina with the Office of Ombudsman for Long-Term Care. Thank you for the opportunity to share support and concerns on SF 5335 on behalf of the Consumer Advocates Coalition, AARP, the Alzheimer's Association, Legal Aid, Minnesota Elder Justice Center, OOLTC, the Office of Ombudsman for Mental Health and Developmental Disabilities. We are very appreciative of the opportunity to work with interested parties to find good solutions to these concerns we have. Residents in assisted living facilities are vulnerable adults with increasingly varied and complex care needs. We encourage this committee to consider 3 key changes to support the safety, health, and well-being of residents in these facilities. First, we hope this committee creates consistency in rights and protections for all vulnerable adults receiving assisted living services. Residents in facilities that provide assisted living and often market themselves as assisted living facilities, but are exempt from licensure due to HUD funding, lack many of the key rights that protect other residents in assisted living, such as safeguards against retaliation and inadequate time and planning for discharge. Second, the Senate language includes training on mental illness and de-escalation for assisted living staff. We have worked extensively with provider organizations to address their concerns in a pending amendment we hope this committee will adopt. And finally, LPNs conducting some 90-day assessments is a significant change in assisted living service. We are concerned a resident's change in condition may get missed if this change is implemented. We encourage the committee to remove this language or include guardrails to ensure all resident health needs are captured in any assessment. We hope this committee can adopt these changes to further enhance the rights and protections these individuals so clearly deserve. We stand ready to work with all parties to reach a fair proposal that accomplishes this goal.
And Ms. Radina, you have that, you sent that because the provisions, if we're coming from the long-term care ombudsman's office, we have that. You got it. I found it. We're good. Thank you. I appreciate that. Mr. Veretti.
Verrett, yes.
Dang
My name is, you had it right the first time. My name is Paul Verrett.
Thank you.
I'm the Public Policy Director for Agate Housing and Services. Our mission is to end homelessness and relieve hunger through action and advocacy. Chair Hoffman, Chair Noor, members of the Human Services Appropriations Omnibus Conference Committee, thanks so much for this opportunity. I just wanted to bring to you 3 very urgent priorities for Minnesotans experiencing homelessness. The first is a task force on simplifying state housing resources. This will produce recommendations to get people the resources they need more quickly, and it will help our staff to work more efficiently and to not use a system where the complexity of it detracts from client care. The second is the proposed Office of Homelessness and Housing Support, an opportunity to centralize and provide more accountability for the services that are very important to us. The third is the approval for the state to apply for the 1115 Medicaid waiver for health-related needs. These measures are all very important for us. They're part of years-long efforts by many legislators, people with lived experience, advocating with authority and expertise, local and county governments, nonprofits of all sizes, and allies statewide. Please continue the momentum on these. Our outreach workers at Agate are working very hard. There are something like 54 encampments in Minneapolis alone, and then statewide there are encampments in every corner of the state. There are people living in unsheltered in all sorts of structures. We've even talked with other nonprofits who have found people living in unoccupied ice houses, for example. And also, our case managers right now are working very hard to guide our clients through an absolute web of conflicting and difficult paperwork and eligibility and other matters. So we really urge your help on this matter. Thank you very much.
Mr. Verrett, thank you. The work that you do is beyond. I mean, it's just something that you look at the homelessness study that's done by the Wilder Foundation, which we should be paying for because it's the information there and the reality of the intersectionality that happens within homeless people that are without housing. It's like Thank you for that, and thank you for your information and what we're doing here. Ms. Radina, do you want to come back up? And then Chakia Richmond, do you want to come on up? Sophia Thompson, welcome to the committee.
Chairs Hoffman and Knorr, members of the conference committee, my name is Sophia Thompson, Deputy Director of Adult Mental Health and Crisis for Ramsey County Social Services. I'm here today to testify on behalf of Minnesota County Associations AMC, MAXA, and MICA. In your packets is a letter from counties outlining several county priorities in the bill. A few items we thank the authors for. Efforts to expand DCT bed capacity. While this investment is far from sufficient to address our state's long wait lists, expanding forensic beds by 16 is a key investment within your limited budget target. Policy changes to min choices processes in both bills will help relieve tension in our backlog of assessments. However, in future sessions, we must continue to work to develop pared-down reassessments for individuals whose need for services go unchanged. The 1115 waiver reentry pilot program in the House bill allows for county jails to explore better continuity of care and outcomes for those who are justice involved when they return to community. Policy language and funding in the House bill to examine targeted case management redesign and associated future local cost. Recognizing the financial strains that costs related to DCT have on communities and relieving select number of counties from those costs. There are two issues we would like to work with the conference committee on the remaining days of the session. First, counties appreciate the attention given to the governance structure of the new DCT agency. I serve on as our lead county on convening with DHS to address county issues with DCT for capacity of staff communication. These conversations are important because they deeply are interconnected, the nature of our work that counties do and our connection to the state system of care. Counties should have a voting position on the future DCT board. A board without any equal county voice is missing an integral perspective when it comes to thinking about how DCT's work fits into our state's broader system of care. And finally, in closing, we have concerns about House language requiring counties to send contracted case management contracts for RFP every 2 years. We share the stated goal of ensuring that contracted case management services are culturally appropriate, but we have concerns about the increased cost and potential disruption of continuity and service to our clients without confidence that the provider network is robust enough to warrant RFP requirements for all counties. Thank you for the opportunity to testify this afternoon.
Thank you, Ms. Thompson. Thank you very much. We're going to go to Ms. Richmond, and then Aaron Huppert, do you want to come back up here and grab a chair? There's some folks that have questions for you and Ms. Radina, so there we go. Come on up. You're the next contestant on The Price is Right. So that is not funny. I'm sorry. Ms. Richmond, welcome.
Thank you for having me. Good afternoon, Mr. Chair, members of the conference committee. My name is Chakia Richmond, and I serve as a member on the Board of Directors for Residential Providers Association of Minnesota. I appreciate the opportunity to provide comment today on several provisions before this conference committee. First, RPAMN wants to express our strong support in the urgent need for the language in the House Article 2, Section 1, that would allow small assisted living providers to relocate their licensed facility. For more than a year, you've heard from representatives of RPAMN on this issue and the unintended consequences of the small assisted living and customized living moratoriums that do not allow the provider to relocate. These limitations disproportionately impact BIPOC-owned, culturally specific providers who often rent single-family homes where they serve clients. When BIPOC providers are unable to move, we are vulnerable to unscrupulous landlords and prevented from purchasing our own settings and building equity in our communities. We ask that the conference committee adopt the House provision with early as an effective date as possible. RPAMN would also like to thank both authors for carrying this bill and a number of assisted living licenses reforms, including food and training requirements, and respectfully request that Conference Committee adopt the House position in House Article 2. Lastly, RPAMN supports the various culturally specific provider education and outreach grant programs contained in each bill, as they will support the ability of BIPOC providers to continue providing culturally specific long-term care services. Thank you for your time.
Thank you, Ms. Richmond. Members, that is the folks that signed up to give testimony, and I know there were some folks that had questions. So a good representative from Osseo, Minnesota.
Maple Grove.
Osseo.
Potato. All right. So the first question I had is, there was some conversation between a couple of you about the LPN section specifically. Can someone identify for me specifically where in either the House or Senate bill that language resides?
Ms. Huppert or Ms. Rodina?
Mr. Chair, Representative Bonner, I may want to phone a friend from Nonpartisan Research to point you to the right page and line on the side-by-side, but it should be in the House position in the Aging Services article.
And yes, we are going to get that. We're looking to phone a friend. I think he was getting way ahead of us when you're...
While we're looking for that reference,
Yeah.
Mr. Chair, would it be possible to briefly sort of summarize what some of those changes are in that language? Ms. Hooper, perhaps you want to start?
Who do you want to, you asking Regina or Hooper? Huppert, Ms. Huppert?
Ms. Huppert, sorry.
Okay, go ahead. Aaron?
Thank you, Mr. Chair, Representative Bonner. The language in the House position would allow an LPN to do a focus assessment every other 90-day assessment that is currently required in statute. So if I were to summarize, there is an assessment that is done for a resident every 90 days under current law. The language would propose that within the LPN scope of practice, an LPN could do an assessment every other, so not to exceed 180 days. And I think, again, these assessments were done by LPNs pre-licensure, and these are assessments that are done in every other setting of a healthcare institution by LPNs today.
Representative Bonner.
Thank you, Ms. Huppert. Thank you, Mr. Chair. And I think this may be for our ombudsman, actually. You had mentioned this section in specific and that you had some concerns about guardrails. Can you help me understand what you mean by guardrails and define that a little bit more in detail?
Ms. Regina?
Chair Hoffman, Representative Bonner, thank you for the question. You know, we recognize this as a significant shift from the intended service of assisted living. When licensure was implemented 2 years ago, the intention was for, and currently remains, an RN to do a comprehensive assessment every 90 days to ensure any changes in resident health and well-being were monitored, were assessed, and changes in care plan could result. And so if we do switch to LPNs doing every other assessment, we are concerned that with a focused assessment instead of a comprehensive assessment, this could mean changes in condition, subtle changes in resident health could get missed, care plans wouldn't be adjusted in a timely manner, and we could see reduced health and well-being for residents as a result.
Ms. Bonner.
Thank you, Mr. Chair. And to our, and I'm sorry, I can't seem to pronounce your last name properly. But so when you say a focused versus a comprehensive, what, can you explain that to me? And I'm trying to understand, because I know that it isn't uncommon for LPNs to fill this role in other settings, hospitals, clinics, et cetera. So I'm just trying to understand the difference here. And then also to understand, if we make this switch and we move to having LPNs be able to step up and help fill that role,
particularly considering that we have real workforce challenges. And let's be really honest. Oftentimes, where we can, we fill in with LPNs. It's not uncommon for them to pick up the slack. That happens in virtually every setting. So if we move, I want to understand the difference between the focused and the comprehensive. And if we move to this shift of the LPNs, what is it that you need to know? Is it having a sign off on the evaluation by an LPN and having them have it signed off by an RN in the facility? What does that look like when you say that? Because you said guardrails. So I'm trying to understand, when you say guardrails, specifically, what do you mean?
Ms. Rodina, and it's my understanding, the House position in this provision, if we're looking at the side-by-sides, is the recommendations from the working group. Is that correct, Mr. Chair?
Mr. Chair, that's correct.
All right, Ms. Rodina, can you, thank you, I didn't mean to cut off the dialogue, but it just dawned on me. So, Ms. Rodina.
Chair Hoffman, Representative Bonner, thank you for the question. In terms of a specific definition of comprehensive versus focused assessment, that is in the Nurse Practice Act, and I am not an expert in that, so I will not venture to give you the full details today, but my understanding is a focused assessment is essentially a smaller assessment than the comprehensive. It looks at fewer aspects of a patient's health. In terms of guardrails, yes, I think a sign-off or some sort of mechanism that ensures that this particular resident at this particular time who has this particular health concern, that they have the skill and awareness of an RN overseeing what is happening for them in that period of time, so that there isn't anything missed in a 90-day assessment, because it would be otherwise it's 6 full months that somebody could go with something that could potentially be missed. So some sort of mechanism to make sure that this assessment is capturing everything it should and has that oversight by a registered nurse.
Ms. Representative Bonner.
Thank you, Mr. Chair, and thank you for that answer. So I think what I'm understanding is that if we were to make this switch, that there is a level of comfort if we were to have, say, a supervised or a nurse supervisor or something be able to sign off on that assessment. And maybe this is for Ms. Huppert, but I think when we're in the facility, if I'm not mistaken, nurses are often very, very busy. And often the people doing some of the day-to-day care end up being the LPNs. So I guess I'm trying to understand if they are doing more of that direct patient care. I'm struggling with how they might miss something if they're spending more of their time sort of picking up that slack and helping care for the patient directly. And that's not to say, nurses are wonderful, LPNs are wonderful, they're all great, right? Not judging, but if they are picking up a lot of that direct patient care, it says to me that they are probably seeing more of the behaviors, more of the issues with that patient. So I'm not really sure I understand how the concern about the gap or what that would look like. And certainly I also appreciate the direction that we'd certainly want a registered nurse to kind of look over that assessment and have a conversation about that patient and make sure that we didn't miss anything. But can you just sort of maybe, Ms. Huppert, you can tell me a little bit about that level of care that the LPNs are providing?
This is, thank you, Representative Bonner. I think Representative Noor, I know who's going to work the difference between the Senate and the House on this one. It sounds like it's happening right now, because we have zero position on this and you have the position, but you're doing what needs to be done. So, Ms. Huppert, I mean, I see a working group happening right here. Should we let them go off into their little, do their thing? Should we give you permission to go off to another room? I'm kidding.
Sure.
Ms. Huppert, go ahead. Thank you, Representative Bonner.
Thank you, Chair Hoffman, Representative Bonner. I think you've described it perfectly. Licensed practical nurses are licensed, trained, clinical professionals. And this is absolutely within their training and their capabilities, and to pretend otherwise is, I think, unfair to their experience. I think the language already in the House position says that a change of condition would require an RN to do that assessment. And I think the last thing I'll perhaps share is the anecdote that was given to me as a non-nurse. If someone takes a tumble, let's say you're walking down the hall and you trip over your own 2 feet, as I have done in the past, an LPN isn't going to just look at your knee. They're going to make sure you're okay. And if you need a nurse, an RN, a 4-year RN nurse to look at you, they will certainly do that. That's within their professional standards, that's within their license. And I would fully anticipate that LPNs are fully capable of doing this work and seeing all of the things that you've just identified, because they're doing this work every single day.
Thank you. Representative Bonner.
Thank you for all of that information. I think I got the information that I needed to hear to help me sort of suss that out, and I appreciate you both indulging all of my many, many questions. I appreciate it very much.
I love that. Thank you, folks, for sticking around. The other part of the equation, and when Susie Scheller, who's the voices elder justice, there is some concerns about the changes. So it'd be nice to see you get that worked out for us, so we can have some kind of. Is there a compromise? Is there something that gets us to where we need to be? Because our focus is patient safety, right? Isn't that? And I will never ever say you're from. All these years I've been saying Osseo, and to this day. So I am sitting here corrected, Mr. Chair. Thank you, everybody, for your testimony. Members, any other points? Representative Noor, do you want to take us to the next phase? I suppose we're going to have to go visit you in the state. Your air doesn't work over there, so I don't even want to go there. Can we go someplace else?
Mr. Chair, I think the next phase is we've got a few days left, and I know we've got a lot of things to finalize. I think it's important for us to find ways that we can agree on few things that are already, that we are same and similar, and then work on some few things that we've been hearing about the assisted living. But I look forward to making sure that the reentry waiver, the health-related social needs waiver, we've got the priority admission, the acute care transition, and DCT. Those are few top areas that I think we can resolve quickly and make sure that the language aligns, and the resources, and also some of the challenges that we've had about assisted living, including thinking of, charging fees for those who are planning to relocate, so that we can take care of that. So I think we've got work to do, and we will be able to come back and next week and finalize everything else. At this moment, I think we can adjourn and come back later.
Thank you. I will take your, are you giving me permission to adjourn, or are you saying that, is that a, I mean, what
It's a suggestion.
It's a suggestion. Is it contingent upon anything, Representative Noor? All right. So with that, members, the information, thank you very much. This really got us to a conversation about what the differences are and what we need to do. We've got a lot of work ahead of us, so I look forward to that. We will adjourn from the Senate, and we will be at the call of the chair. Is that correct, Mr. Chair?
Thank you, Mr. Chair. We'll be posting once we have the next step to go forward next week.
All right, we are adjourned.